Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Hair serves an important cosmetic function in humans. Both lack of hair and excess hair can cause significant emotional distress. Loss of hair in a patterned manner called patterned hair loss, also known as androgenetic alopecia. This word is more often used for men. What word? Androgenetic alopecia. In females, it is generally called female patterned hair loss. Because in females, not only the androgens, various other reasons are also there to cause baldness or loss of hair. This androgenetic alopecia is the most common cause of baldness in both men and women, affecting 50% of the population. Coming to its pathogenesis, twin factors. One is genetic predisposition, which is inherited in an autosomal dominant fashion. Next, the main culprit here, androgens. If there is excess androgens in a genetically predisposed individual, it will lead to loss of hair in a patterned manner called patterned hair loss or androgenetic alopecia. Genetic predisposition in an autosomal dominant manner, androgens, both in a single patient, twin factors leading to androgenetic alopecia. Next, what is the pattern? In which manner there will be loss of hair? In men, bitemporal and frontal recession of hair, means loss of hair in bitemporal and frontal side. Here you can observe bitemporal and frontal recession of hair, and baldness on vertex. Here you can observe complete baldness on vertex. In male, both baldness on vertex and frontal and bitemporal recession will be there, whereas the pattern in female will be either diffuse thinning over crown with intact frontal hairline. Here you can see frontal hairline is intact, whereas entire crown has diffuse thinning of hair. Either this pattern or frontal accentuation of hair loss. Here you can observe frontal accentuation of hair loss. Either this or this. Any one in single female. Whereas in male, both baldness over crown and frontal and bitemporal recession is present in a single male. Men are more affected here than females. Why? Because females have low androgen receptors. Low 5-alpha reductase enzyme, both isoforms 1 and 2. What this enzyme will do? It will convert testosterone to most potent form dihydrotestosterone, which is the main culprit for loss of hair. Then it has high cytochrome P450 aromatase enzyme. It will reduce the burden of the culprit androgen testosterone by converting it to estrogen. Because of all these reasons, female hair over frontal and bitemporal area is saved without recession, whereas like in men. So I already told you it is autosomal dominant in inheritance. Then male and female has to be affected equally, but here because of these reasons, men are most affected than females. Men in their 50s, 50% will be affected. In 30s, 30% will be affected with this androgenetic alopecia. As compared to men, thus reducing the severity of hair loss because of these three reasons. The characteristic feature of androgenetic alopecia is number 1, progressive miniaturization. Progressive means not sudden. Slowly it will convert the terminal long hair to vellus hair, which is small miniaturized hair. Then decrease in anagen duration. Anagen phase is the growing phase of the hair. If no growing phase, no hair will grow. These changes are more pronounced with each cycle, and finally baldness ensues over years as it is progressive miniaturization. So it takes years. In both men and women, occipital hair is spared as they have no androgen receptors. Why? Because occipital area of the scalp is derived from mesoderm. Remaining areas of the scalp, crown, frontal area, bitemporal area, which there will be hair loss because they are derived from neural crest. All those areas hair is sensitive to androgens. Here occipital hair is resistant to the action of androgen because they have less androgen receptors or no androgen receptors at all. The fact that the occipital hair is resistant to baldness when transplanted over bald areas is the basic principle on which hair transplantation is based on. This is called as donor dominance. To get a clear idea, wherever the occipital hair is transplanted, in whatever the environment, if it is androgen high area also, this hair will continue to grow as it is resistant to baldness as they have no androgen receptors. That's why this hair is used for hair transplantation. Be like occipital hair without losing the character. Whatever the environment or situation we are in, always do ethical and moral practice. Coming to algorithm for management of androgenetic alopecia. In men, if the disease is very advanced, then we can go directly to surgical hair restoration. Means hair transplantation with our occipital hair or cosmetic aid. What is meant by cosmetic aid? Wigs, hair extensions, hair pieces, pigmented creams to camouflage the bald scalp to look like a hairy one. Then if the disease is not in so advanced stage, you can try with first medical management with 2 or 5% minoxidil solution BD with or without finasteride. Finasteride is category X drug, means teratogenic. At whatever cost, we have to avoid it in reproductive aged female. So here only men we can give finasteride as an add-on to minoxidil. Whereas in females, we have to see for signs and symptoms of hyperandrogenism. Why? In females, if there is more androgen, more hair growth will be there in unnecessary areas like beard, mustache. It is undesirable for female. It is called hirsutism. To have a clear understanding, I already uploaded a video on hirsutism. Go and watch it for this algorithm to how to evaluate hirsute women. Here, if there is signs and symptoms, we have to evaluate and find out the cause. If there is any hormonal problems found, yes, we have to go and treat the cause. Then automatically this androgenetic alopecia will improve. If not improved, or we are unable to find the cause for signs and symptoms of this hyperandrogenism, the culprit, then it is idiopathic hyperandrogenism. We can go for hair transplantation or cosmetic aids. Here already androgens are excess. We don't know why it is in excess. We are unable to treat it. So if we give minoxidil also, these androgens are going to make the hair fall. So we can go directly hair transplantation or cosmetic aids in this situation. If there is no hyperandrogenism, still there is loss of hair, that is androgenetic alopecia, then we can try medical management with 2% minoxidil. FDA approved only 2% for female BD. For 6 months it's not getting improved, then we can add an anti-androgen or go for surgical restoration of hair or cosmetic aids. Finally, what is anti-androgen? In females, cyproterone acetate or spironolactone, not finasteride. We can give when if the woman is postmenopausal or not wanting to conceive, then we can go for finasteride in females. Otherwise, in a reproductive female, never give finasteride. Coming to medical management of androgenetic alopecia or patterned hair loss. Minoxidil with or without anti-androgens. This medical management takes 6 to 12 months to show results. How to use for long term. If stopped abruptly, hair density reverts to the state it would be without treatment. That means benefits, whatever the benefits are there, it will be lost in 6 to 12 months. Benefits will get slowly. If we stop, then benefits will also go back to the state without any treatment to that state in 6 to 12 months slowly. Coming to minoxidil, what is it? It is a category C drug. First it was being used as an antihypertensive. Later it was noted hypertrichosis as a side effect of minoxidil, leading to its development as a topical agent for hair growth. What are the formulations available? 2% solution in 60% alcohol, 5% solution in 30% alcohol, 5% foam. Coming to mechanism of action, it increases the duration of anagen growth phase. So hair will grow lengthier and gradually enlarges miniaturized vellus hair to mature terminal hair by unknown mechanism. Some proposed mechanisms are there, as it is an ATP sensitive potassium channel opener and leading to vasodilation. It increases adenosine triphosphate, which increases adenosine, which leads to more and more vascular endothelial growth factor and prostaglandin E2. Both promotes hair growth, which we want in androgenetic alopecia patients. Coming to FDA approved uses, for men 2% and 5% minoxidil BD. For female only 2% is approved. 5% for female is not FDA approved. What this minoxidil will do? First it will cause vellus hairs to grow in 4 months. It takes 4 months to show its action. Immediately after using, there may be more and more hair fall, that is whatever the hair is in telogen phase will go to catagen phase and then fall off. We no need to fear and stop minoxidil. We have to continue consistently BD for a period of 6 months, then only we can observe results. First vellus hair has grown, then whatever the terminal hair is, it will also start growing, and then number of hairs also will start to increase. This minoxidil is most efficacious on crown area. Coming to off-label uses, alopecia areata, loose anagen syndrome, congenital hypotrichosis. It can be given before and after hair transplantation, as it improves function of suboptimal follicles and makes it ready to get transplanted onto the bald area. Then after transplantation, it optimizes the survival of transplanted follicles. When we have to give it, not on the immediate next day of transplantation, it should be started after a week of hair transplantation. Coming to side effects, irritant and allergic contact dermatitis, hypertrichosis of skin. Hypertrichosis is the desirable effect which we want, but here other than the scalp if applied inadvertently. Coming to anti-androgens. The main culprit in androgenetic alopecia, name itself telling us it is androgen. So we can also add on an anti-androgen. Spironolactone. It reduces androgen synthesis and androgen receptor. It is an androgen receptor inhibitor. It also inhibits 5-alpha reductase. So mainly spironolactone is a androgen receptor inhibitor. It is used as a diuretic, mainly FDA approved use. Only off-labelly we are using for androgenetic alopecia, hirsutism, acne, hidradenitis suppurativa. All these 4 diseases are related to androgens. Coming to adverse effects, it may cause GI abnormalities, hyperkalemia. It is a potassium sparing diuretic. It will eliminate all the sodium and water from the body but holds potassium, which may lead hyperkalemia. Every anti-androgen will cause decreased libido. Without androgen, there won't be any libido. And gynecomastia. Men may attain features of females like breast, gynecomastia, and feminization of male fetus. So we should avoid it in pregnancy. If androgens are present, fetus will form a male fetus. If absent androgens, then it will become obviously female external. It will attain obviously female external genitalia. Next, cyproterone acetate. It is a teratogen. It is also an androgen receptor inhibitor. Same, flutamide is also an androgen receptor inhibitor. Until now, we have seen 3 androgen receptor inhibitors: spironolactone, cyproterone acetate, flutamide. Same, cyproterone acetate is used off-labelly for androgenetic alopecia, acne, hirsutism. Flutamide also for same off-label uses. Both will cause hepatotoxicity. Flutamide will cause fatal hepatotoxicity. Next, 5-alpha reductase inhibitors. 5-alpha reductase has 2 isoenzymes, 1 and 2. Finasteride inhibits second isoenzyme. What is this 5-alpha reductase? It will convert testosterone to more potent form, that is dihydrotestosterone. It is the main culprit. More than testosterone, dihydrotestosterone is the main culprit. Now here it is inhibiting this formation of dihydrotestosterone. It has got FDA approval for androgenetic alopecia in males. Remember, for males we can add an anti-androgen, that is finasteride only, because it will work. This enzyme is present mostly on frontal area and vertex area, which is male patterned baldness. For females, it is off-label use for hirsutism, acne, and hidradenitis suppurativa also. As with any androgen, it will decrease libido, gynecomastia. Dutasteride, name itself telling us due, it will act both isoenzymes 1 and 2. Off-labelly, we can use it for all here: androgenetic alopecia, hirsutism, acne, hidradenitis suppurativa. Along with these 4, one more: frontal fibrosing alopecia also. Next, ketoconazole. We all know it is an antifungal at 200 mg dosages. Now here we are giving high dosages, that is 400 to 600 mg. Only at these high dosages it will inhibit this CYP3A4 enzyme and inhibits androgen biosynthesis. In androgenetic alopecia, ketoconazole shampoo can be used as an adjunct to minoxidil. Then it is used in hirsutism also. Side effects are headache, hepatotoxicity, hair loss, and nausea. Combined oral contraceptive pills, preferably third and later generations. First and second generations will have progesterone, which we can't use for controlling androgen. It will have androgenic effects. Later, third generation, later on generations, they will have anti-androgenic effect. Now we want anti-androgenic effect, so we will use only third generation or more. It is a category X drug. It inhibits LH-FSH, ultimately inhibiting androgen synthesis. Same with GnRH analogs. If we give GnRH analogs like leuprolide acetate continuously, it will also inhibit LH-FSH, ultimately inhibiting androgen synthesis. No androgens, no androgenetic alopecia. FDA approved use for OCPs are acne. Off-label, you can use it for androgenetic alopecia in female hirsutism. Same with GnRH. OCPs are prescribed only when female does not want to conceive. Side effects are headache, melasma, migraine, increased risk of venous thromboembolism. We all know estrogen causes this increased risk. GnRH analogs causes hot flushes, osteoporosis. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.